Thank you, Mr. Chairman. Good morning, everyone, and thank you for the invitation. Congratulations also for the venue, for the progress of the society. I'll look once again in person, many friends. That's a great occasion to interact with each other. So my task today is to talk about the risk of malignancy. This is my disclosure. And indeed, IBD is an intriguing model among chronic inflammatory disease because we know that chronic inflammation may increase the risk of cancer because of dysregulation in immunosurveillance. And on the other end, the medication that we use as immunosuppressor may reduce the inflammation, at the same time also increase the risk of cancer. And then as the population aging, the prevalence increase of IBD, we will face for the future more and more the situation of patients with IBD with cancer. Then outline will be to discuss about the background risk of cancer in IBD, to touch upon the risk of cancer for individual therapy that we use in IBD, and also to discuss together what can be the management of IBD when there is a cancer. In terms of background, when you look to the cancer risk, one very solid outcome is mortality for cancer. And this is coming from a very solid population-based study from Denmark. They have a great registry there. And you can see in UC and CD the comparison of the change in mortality for cancer compared to infection or compared to cardiovascular risk. And you see that it's significantly increasing over time. It is significant increase in both UC and CD. And this is progressive increase over time. You may see that will be lower compared, and we heard already about the cardiovascular risk, but it's still substantial, and from 7 to 45% increased risk of mortality. Now, we know that many cancers of GI tract are increased just because of the inflammation. You see there the standardized risk of this cancer. This is 5.7 for colorectal cancer, quite higher for small bowel adenocarcinoma and for intestinal lymphoma, quite a lot for cholangiocarcinoma. But you know there is a quite difference in terms of risk, in terms of increased risk for the background population and absolute risk. So some of these diseases are very rare, so if the risk is increased, the number are not such high. So we have to put in the context, which is the real risk of the patient, also to discuss which is the background risk when we face also with eventually the increased risk of the therapy. And you see there, this is the background risk of cancer in IBD. You see the first most common is not melanoma skin cancer, 900 patients every 100,000 patients here. And going below, you see colorectal cancer and melanoma, small bowel, and very low absolute risk for lymphoma, for cholangiocarcinoma, lung cancer, and leukemia. So this is the background situation for every of our IBD patients. So the bottom line of this first introduction is the background risk of cancer in IBD is increased because we know that the mortality is increased. The major increase is parallel the duration of the disease, and is highest for cholangiocarcinoma and small bowel carcinoma, but the burden comes mainly from colorectal cancer and small bowel cancer and lymphoma. So in this situation, basically the key is to control inflammation. The best we control the inflammation, the best we can reduce and put just in the background risk all this population of patients. Looking to the therapy now. So mesalazine. Well, we know there is not increased cancer risk there, and on the other hand, eventually there is a chemoprevention rule, although probably we need still high quality, but none of you will ever come prospective trial to really evaluate the value of this prevention. That in the last meta-analysis you can see is about 60% reduction risk, and this is more for mesalazine, is not such for sulfasalazine, also because the number they are reduced and is not achieve a strong statistical significance. What about corticosteroids? Well, in general, we believe there is no increase in cancer risk. But once again, if you look to this population-based control study from Denmark, there is an increase, although only 10-15% of non-melanoma skin cancer and non-Hodgkin lymphoma in patients with long-term use of steroid, which basically should be not the case for IBD. Looking to theoporins, well, we know that they increase the risk of cancer. This is solid, and this is based on the incorporation of 6-thioguanine instead of guanine during the DNA change replication. This will modify the replication system, although it can be somewhat controlled by the mismatch repair system that may escape this kind of mechanism and lead to cancer. And there is a very strong evidence that thiopurines increase the risk of lymphoma. The standard risk is about 6, and this is under therapy. When we stop the therapy, this risk is completely drop out. And this risk is increased in men compared to women. And there is a population with even more risk, which are patients over 50 years, where you see the risk is 2.6 every 100 patient years, while there is a low risk in the mid-age, so basically from 30 to 18 for 40 years, when the risk is less than 1 patient every 1,000 patient years. So in general, this risk doesn't increase on the duration of treatment, but stay as long that we are on the treatment, and is stopped when we stop the treatment. And if you see here, this is coming from the large group of database from France, the SESAM study, and it's very clear that if you're still using to treat the patient over the age of 70, the number needed to treat are only 15. So it's very clear that in that age, if still these patients are on thiopurines, if you're doing well, you have to stop the therapy. What about the skin cancer? Well, IBD patients receiving thiopurines are at increased risk of non-melanoma skin cancer, and this is solid. And what is not completely clear if this risk will remain when we stop the therapy. So once again, this is lead to the incorporation of 6-thioguanine in the skin and the effect of ultraviolet A, and this will give to DNA damage. And curiously, there is a change in the predominance occurrence of squamous cell carcinoma in spite of basal cell carcinoma, which is the most frequent one in general population. And you see the risk is almost double. So once again, we don't know in the SESAM study, basically even after stopping the therapy, the risk was still increasing. This has not been confirmed in other 2 population-based studies from Canada and from the Veteran Administration. So apparently when you stop the therapy, no more still risk of non-melanoma skin cancer there. What about methotrexate? Not that many studies in IBD, not that much used, not that much number there. Most of the studies are coming from rheumatoid arthritis, even they're probably underpowered. What is clear, there is probably a modest increase on non-melanoma skin cancer in this population. So what is more important is to look about the situation. More and more patients are using biologic. What about the situation anti-TNF and cancer? We have quite a lot to study there, not only in IBD, but also in rheumatoid arthritis. These are all meta-analysis and systematic review. The last one that you can find in the literature, a 50 randomized trial, quite a lot of participants. You see there is not clear difference for any kind of anti-TNF use. In this slide, you see also natalizumab and vedolizumab were listed, even there, no change. And basically, this is the last recommendation that comes from the update ECO guidelines. There is no evidence that there is an overall excess risk of cancer in IBD patients treated with anti-TNF agent. Now, when we go to lymphoma, there was some discrepancy at the beginning because it was very much correlated to the number of patients that were reported. Lymphoma is not such frequent. The number of population that were reported in the beginning was not such large, and the risk was probably underestimated. But if you will see in the next slide, hopefully, indeed, when the new large population of France was added, and this was Lamatri in 2017, there were more than 200 patients with lymphoma that were compared with or without therapy. Pulling together in the meta-analysis that was published in 2020, there was a clear, significant increased risk of lymphoma with anti-TNF, was approximately 50% risk when using anti-TNF alone. This risk was even higher when was using thiopurine alone, was more than double.